We have a list of questions, Dr. Scionti, sent in by our listeners. Some of them are just coming in. We will just quickly go through them. We have about 15 minutes to address these. We have a couple of questions asking about the side effects and recurrence rates of HIFU. So maybe you could take a few minutes to explain that.
Okay, that's really central to our discussion. I think the first thing to understand is that with recurrent rates, and they really are, recurrence rates are proportional to the grade and stage of the disease across every single treatment. There's no question about that. So if people are making claims about any treatment and saying, if I've got a Gleason grade 7 stage T2B prostate cancer and I treat it with any technology, whether it be surgery, radiation, or HIFU, and I get a 98% biochemical recurrence-free rate, that's just incorrect. That's not going to happen with any modality today. So I think that what I tell patients is that, once we understand graded and staging, we can give them an estimate of where recurrence rates are in published data. And I think some of the data, especially out of the longer-term work from Yoshida, from Creuset, from Chaucer, really suggests those biochemical disease recurrence rates are pretty favorable. Now, are they? Has anyone ever done a prospective head-to-head comparison? No. And so it's very dangerous to make statements about HIFU being superior to anything in terms of recurrence rates. You cannot say that. Now, side effects are related to two things. How much of the gland do you have to treat? It's related to where you put energy. It's also related to experience. If one targets the rectal wall with this technology, there's a risk for rectal injury. Having said that, proper training should avoid that, and that should become a very rare event with proper training. So side effects really depend on practitioner experience. They also depend on the grade and severity of the disease. If one's trying to treat bulky extraprostatic disease, there will be more side effects. There's no question.
And what sort of rate of good erectile function would you expect to get in, say, a common or garden T7, T2B case today?
Yeah, no, good question. I think that depends on whether or not you can spare the neurovascular bundles. And to making that decision, I use MRI extensively. So you'll see in the radical prostatectomy community a lot of surgeons beginning to use MRI to make those decisions. I believe MRI is helpful for HIFU to make those decisions as well. So if the tumor is bulging the capsule near the neurovascular bundle, I don't think you can preserve that bundle with any treatment at all. So to tell a patient with a T2B lesion that the lesion is infringing upon the neurovascular bundle, to promise that patient potency is incorrect, because if you do that, you're going to spare tumor. Now, the converse is if the tumor really is well demarcated, interior to the capsule, away from the bundle, the patient's a candidate for nerve sparing, and we treat the entire prostate, we can look at about 80% of those men having a functional erection by 3 to 6 months out. If one does a totally focal procedure, a minimal procedure, treats 1 or 2 centimeter lesion well away from the bundles, that patient can expect better than a 90% return to potency very quickly. But it depends on the disease, it depends on the location, and I think this is where the diagnostics are really important in terms of giving patients proper advice.
Thank you. Priya?
Thank you, Mike. Dr. Scionti, John writes in from the UK. He says, I'm in the UK where HIFU is approved on the NHS. For low volume, low risk Gleason 6 men like me, is this treatment the best currently available and with minimal side effects?
Okay, so John, the real question is how old are you, and are you a candidate for active surveillance? And is active surveillance? You can't have fewer side effects than active surveillance, but understand that there's a lot of psychological load that goes with active surveillance. So, yes, I mean, may you be an excellent candidate for HIFU? Yes, prostate size is critically important. If you've got a small lesion, a small prostate, you may be an excellent candidate. If you've got a small tumor in a very large prostate, you'd be a very poor HIFU candidate. So it really goes down to an understanding about the load of disease, the location of disease, the volume of disease, and I think the UK has really taken the lead. A lot of the folks have taken the lead with MRI imaging, and so I think looking at some of the work done at the University College of London by Mark Emerton and his colleagues, I encourage you to look, because if you've got Gleason 6 disease and it's a large enough tumor and it's well seen, you may be a candidate for a focal ablation. So, I think going back to a personalized approach is very important.
Thank you, Doctor. The next question is from Mike, who asks, can results for HIFU treatment be expected to be similar for areas outside the prostate, like seminal vesicles, lymph nodes, bladder, neck, as normal treatment to the prostate bed?
The short answer to that is no. HIFU is an ablative treatment, is best used for very localized disease. If the advantage to HIFU is low side effects, treating men with advanced disease, especially in neighboring structures, is going to produce a lot more side effects. So in my practice, if I see a patient that's suspected of having extensive seminal vesicle involvement, or tumor encroaching on the bladder neck, or certainly any risk of lymph node involvement, I'm generally referring to those patients to my radiation therapy colleagues. We're not treating those patients with HIFU. So, again, it's really not designed for extensive disease. Now, interestingly, Christian Chaussy has published some work out of Germany looking at a series of patients with bulky advanced disease, and looked at that as a disease palliation mode, and reports that they've done fairly well. But that's certainly not where we think about HIFU classically, and I don't think that's where we ought to see it used in the United States.
Thank you, Doctor. The next question is, EDAP's Ablat was also FDA approved on November 9th. They have a fully robotic model with MRI imaging focal one that is also expected to be 510K cleared. Could you please comment on this?
Yeah, we talked about that a little while ago. Yes, I think it's an excellent platform. The Ablatherm platform has been extremely well studied. The Focal One has got MRI integration. They will get a 510K on that, and I think it's really going to be more of the experience of the surgeon than it will be of which particular machine they use. Both machines are capable of getting excellent outcomes. I think it really comes down to proper patient selection, proper execution of the treatment by an experienced surgeon, and proper care of that patient post-op. But I'm excited to see their technology in the United States, because I think that surgeons need to have a choice and use which platform they feel is going to suit their needs the best. But yeah, I think that's very important that we have both of these available.
Thank you, Doctor. There's a caller online. Person calling in from 206-240-0133. You're on air. Please ask your question.
Okay, can you hear me?
Yes, we can.
Oh, good. Well, this is Mike from Seattle. Doctor, I've talked to you before about 6 weeks ago, and you answered one of the questions I had about seminal vesicle treatment with this new machine. In my case, that's what I'm going to have to do, a bilateral treatment, both the right and left. And I wondered if you've actually had done that when you were in, the Grand Cayman and Bahamas experience. Or I think, like I say, you just answered that, but have you ever actually done that?
Okay, so done a complete gland treatment, or treating well into the seminal vesicles?
Just the seminal vesicles, the biopsies, and the C11 choline. Just a refresher, we're okay on the prostate bed, confirmed by biopsy that there's nothing there. Yeah.
So again, you look at the optimal patient for HIFU. It's a localized disease patient, right? But if we've got an isolated lesion that we know, and it's just into a seminal vesicle area, and we can see the area, there's no reason we can't put energy there. The problem is, and the risk is that once we see seminal vesicle disease, and this is true of any treatment, any localized treatment, even though our studies for metastatic disease are negative, there is a very significant risk, at least microscopically, of disease that's been disseminated throughout the bloodstream or disseminated into the lymph nodes or the bone scan, and it's not being picked up by these assays. So the short answer is, if we see an isolated lesion, even if it's in the seminal vesicle, we can target it. The uncertainty is, as good as the studies are for metastatic disease, the studies don't totally exclude metastatic disease. And if there is disease that's distant and not being detected, then treating a seminal vesicle lesion, for example, won't be curative at all because there's disease elsewhere. And that really is because we don't have, even given some of the assays you mentioned, we still don't have a totally sensitive test for microscopic disease that's well outside of the prostate. It still doesn't exist today, and that's the challenge.
Okay.
Thank you, Doctor. There's another caller online. Caller using 703-425-5141. Please ask your question.
Okay.
Thank you, Doctor. There's another caller online. Hello. Using 703-425. Please ask your question.
Hey, hello, Dr. Scionti. Thanks for a very informative talk. I would like to know, are you tracking your own results systematically, as in all consecutive patients? If so, would you care to share your results, or do you expect to be able to announce your results at some time?
Okay, so, over the last 10 years, patients have been treated in 8 different foreign countries, literally from all over the world, without a university research team behind me, much as exists in the UK, for example, or in Japan with Dr. Yoshida. So, do I have some results? Yes. Are they robust to the point where there's no missing data points? No, that's just been impossible to do. So, going forward with the introduction in the United States and formal protocols, formal companies behind this, that will be much more feasible to do. Okay. Now, what I do have and what we're working on pulling together is I have a subset of patients that have been well tracked who have focal treatments. In focal treatment, I'm very insistent, and anyone that's seen me for a focal treatment has heard me say this, is that we're going to follow patients very carefully, and I'm going to insist on MRI follow-up and a biopsy at the 1-year mark to document the complete ablation of the tumor, as well as to look at the rest of the prostate to be sure there's not been a development of tumor in the remaining healthy tissue. That's a fairly robust series that we're actually trying to put together right now. So I think we're going to see a lot more of that now that treatment's centralized in one location with that people are, that are much more organized in that manner. But as you can imagine, with people treated at 8 different centers over 10 years, that's been very difficult to do.
And Dr. Scionti, how many patients are in that focal therapy series, roughly?
Roughly right now, with good data, we've got about 90 patients.
And how long is the series? In other words, what
the first patient was treated about 4 years ago.
Okay, thank you. So I have one more question before we end the call, and that is, this is now the third. We now have two types of HIFU approved. One of which is the Insightec equipment that was originally approved for the treatment of metastatic pain. Do you expect to see HIFU being used more in the palliative area in due course, in the sense that it can probably be targeted in ways to treat isolated lesions in places where radiation can't be used?
The potential's certainly there. The potential is most definitely there for example, for bone tumors and bone pain. Any area that one can target is potentially there. So I think now that we have technology available in the United States, I think you are going to see, under clinical trial protocols, I think you are going to see that studied. and that certainly is an area for expanded use, and where I think it could be of benefit. But I think that has to really be studied in an organized manner. And now that there are platforms that will be available, they'll be at universities, they'll be at centers where this work can be done. It's just I think you will see that being used outside of the urology department.
Well, thank you very much indeed for your time, Dr. Scionti. I'm going to hand this back to Priya for us to sign off, but you've been very forthcoming this evening, and I think people have learned a lot about the opportunities that may exist in the near future and in the longer term as well. Thank you.
Well, thank you for the invitation to be on the show.
Dr. Scionti, it has been wonderful listening to you. The approval of HIFU is hopefully definitely going to be a turning point for treatment of prostate cancer in America. With that note, I'd like to wrap up today's Cure Talk. Thank you, Mike, Alan, Jim, and Tony. This talk is available on Cure Talk's website. Please visit curetalks.com for details on upcoming talks. Thank you, everyone.
Thank you, Dr. Scionti. Good night. Thank you, everybody.
Good night, everyone.